60 slides in this presentation in an hour, which is perfect timing. So the learning objectives. I put on the slide everything you actually need to know from this introduction to pharmacokinetics. So by the end of this lecture, you should be able to figure out how drugs move across membranes, what's the difference between weak acid and weak base, at the same time predict will the drug be readily or poorly absorbed, and what's the connection between the pKa and pH for an acid or a base, and how this affects how much of the drug gets transported across membranes, and why this is an important concept. Also, you need to know what's the kind of different routes of administration of drugs, internal drugs versus parenteral drugs, and describe fluid volume for the major compartments. You know how much of total water we have, or extracellular fluids versus plasma versus just blood. And also describe the factors that determine rate of distribution of a drug across different compartments of the body, and the factors that tend to make the rate of absorption or distribution of some drugs more rapid than others, and what decides what gets into the brain or the CNS versus not, and how binding to the plasma protein may affect the binding and distribution of drugs. Some of these we're not going to cover in too much details, but we'll just touch bases on them. Discuss the phenomenon of redistribution, and at the same time explain how to calculate the volume of distribution and the loading dose and maintenance dose. We're not going to cover the maintenance dose today because it requires a knowledge of clearance and drug elimination before you actually know how you calculate the maintenance dose. So that's going to probably stay to the next lecture. Okay, pharmacokinetics. So in general, in order for a drug to reduce its action, it has actually to reach to the site of action, which is the binding to the receptors. So if you get any drug administered with whatever route of administration, unless it makes it to the intended action site, which is the binding to a receptor or inhibiting of a receptor, in enough concentration to reduce its action, it's not going to work. So pharmacokinetics is the science that deciding which dose to use, how much to use based on which route of administration. So drugs move across different compartments, regardless where they are entering the body from, unless you just directly deliver them to the plasma, which is via the intravenous administration, then they have to cross different barriers. And this transportation across different barriers is the absorption process. Once in the plasma compartment or the blood compartment, unless it acts in the blood or the plasma, which may be a drug that acts as a chemotherapeutic agent and kills the leukocytes in the plasma. Otherwise, if it's intended to be acted somewhere else other than the blood, it has to cross back from the blood to these tissues or these organs in enough concentration to produce its action. And then for a drug to produce its action, you actually have to reach steady state concentration, which means you have a stable level of the drug in the body all the time. Drugs generally don't stay at their site of action. After they do the action, they dissociate from the receptor and leave the site of action. They go back to the circulation, and from there they get excreted or eliminated. We have to know that when you give 10 people the same dose, not all of them will respond to the same dose, even if you correct the dose, their weight and their gender and their height and everything. That doesn't necessarily mean they will have to reduce the same action in every subject. So there are multiple factors that will decide how much of a benefit a subject will get from this specific dose. Okay, so one part of the process of pharmacokinetics, you have the absorption and distribution, then the elimination, which we'll cover next lecture, which can occur either by excretion, so the drug gets excreted in its basic form or its variant form with no modification, or it could be metabolized. So part of the metabolism listened last time about the liver role in metabolismal drug breakdown and the first pass effect. This is the part of the elimination process that the liver breaks down the drug or metabolizes to more easily excreted form or less reabsorption form. Then it gets excreted via the kidney or via the liver into the bile or via the sweat glands. So it can leave the body in multiple routes, but it has to be actually either excreted directly or eliminated via metabolism. So the pharmacokinetics is the science that describes these four parts, the ADME phenomena, which is absorption, distribution, metabolism, and elimination. So when you get a drug, you actually have to you start with drug absorption. Sorry. So the dose gets absorbed from the stomach, so that means it has to be liberated from its dosage form. When you get a tablet, there's multiple components to the tablet in addition to the drug. You have a filler, you have a binder, you have a coat, if it's a silica, if it's enteric coated, you have maybe a gelatin capsule, if it's intended to act in the intestine. All these parts have to disintegrate first, and this disintegration process could sometimes be the limiting step. Then after the drug is disintegrated and liberated from its dosage delivery form, then it gets to the stomach, and then you get the absorption, where it crosses to the blood in the form of a free drug. And the only active drug is the free drug. So the drug could exist in multiple forms, could be bound to tissues, could be bound to like lipid soluble component. It could be also as a reservoir where you bind the drug to something that's not easily, readily transferring the membrane, so it stays into the muscles for a longer time, which is the depot formulation. Then it's only that part that gets liberated and become free that can cross these compartments and bind to the receptors. So this free drug can go to the site of action, which is the receptors, and at that site of the action also binds, part of it binds to the receptors, and part of it stays free in the surrounding area. And we get turns where the part of the drug binds to the receptor, gets the action, then leaves and gets metabolized and replaced by another free drug. So it's like you're constantly hitting the receptor with free drug. So sometimes you add higher doses just for you to have a steady level of activation of a receptor or inhibition of a receptor. So usually the drug, when we say central component, we mean the plasma or the blood. There it can bind to plasma proteins, and the part that binds to the plasma protein, first, it's not active. Second, it's safe and protected from excretion, because the part of elimination, excretion in the kidney, it has to be also a free drug. So it acts as a reservoir to delay the excretion of the drug and prolong its action. For that free drug also, you can have part of it goes and bind to unwanted side of action, which started to cause the phenomena of side effects. If the drug is intended to work, say, in the stomach or in the muscles to relieve the pain, most of the non-steroidal anti-inflammatory can work on the muscles and relieve your pain, or work on the back muscles. But at the same time, it can go and work on the stomach and the intestine and cause ulcers. This is not a wanted action, but at the same time, it's part of the drug being free to go everywhere where it can cross across the membranes. The termination of the action of the drug is usually through metabolism, where it goes to the liver and by transformation, it gets metabolized and gets excreted. So, again, it's the absorption, distribution, metabolism, elimination that what decides how much of this drug will act and what kind of action you expect. This is like a schematic representation, and we just added here the parts of the body that takes action or contribute to the action. So drugs when given orally or intravenous or intraperitoneal or subcutaneous or intramuscular or by inhalation. These are the most commonly used route of administration. I'm going to cover more routes in the next slide. They get absorbed across membranes, either that be the membranes of the oral cavity, GI tract, the peritoneum, the skin if you give the drug through transdermal patches, muscles if you give the drug directly intramuscular injection, or the lungs if you give inhalation, as most of the anti-asthmatic drugs. Then it goes to the binding protein within the blood, and from there it goes to either to the bone and the fat, which act most of the time as a reservoir, where drugs can linger there forever, and some drugs' toxicity is simply because they stay in the bone and the fat for a long time. And this is also one of the phenomena that's used for toxicological identification. Somebody gets the drug and die later, maybe 10 days or 2 weeks or 3 weeks later. You can tell that from analyzing the bone and the fat from some of these drugs that they were exposed to a poison. Like the arsenic can stay in the hair for forever. Like now we're analyzing samples from the pharaonic eras, and we can say this king or this queen was poisoned by arsenic from the traces of arsenic, and there remains hairs. Okay? Then when the drug is metabolized, it gets excreted. Excretion could take part in the intestine through the bile, or in the kidney through the urine, or the lung through the expired air, or sweat glands, and multiple routes of excretion. Okay, routes of administration. Enteral administration, or per os or VO, that means through the mouth or through the GI tract, could be a tablet or a capsule or a liquid or a suspension, or even a long-acting preparation, sustained release preparation, where you have micronized capsule that could act for a longer time. Could be also sublingual. Most of the common drug sublingually given is the nitroglycerin. One of the most famous drugs for angina attacks. You just get a tablet under your tongue, and in a few minutes you're fine, because it acts directly and reaches the circulation directly, bypassing most of the factors that will delay absorption. Parenteral administration, you could have the drug administered intravenous into the venous circulation, or intramuscular, or intraperitoneal, and this is where most of you guys, if you're going to work with animals, this is the most common route of administration in rats. Mainly you give the drug intraperitoneal because you don't want to have an IV line or intra-arterial line, which is even difficult to maintain. Subcutaneous, and which is like most of the insulin drugs are given subcutaneous administration. Or intrathecal, this is the most common route for administration of anesthetics. If you go to have a surgery, they usually try to go to the central of your back and do a spinal block with a nerve block, Bupivacaine or other drugs, when they actually inject into the spinal cord, into the thecal area, and that paralyzes or cuts the nerve supply of the vein for the lower part, below this point of injection. Pulmonary administration, either intended or not intended, so it could be gas, or when you put somebody under halothane or any other inhaled anesthesia, usually it's a gas, or vaporized drugs. Most of the anti-asthmatic drugs is simply a capsule that gets vaporized by inhalation and then gets access directly to the lungs, and from there to the circulation. Transmucosal is through the mucous membranes, could be rectal administration or nasal administration, or for the eye drugs, it's mostly, or the otics is mostly through the transmucosal membrane. Dermal, such as creams or ointments, or patches, especially these 24-hour patches now for nicotine cessation or even nitroglycerin. So this is a schematic diagram. Once you get the drug with this route, where it goes. So you could have the drugs being administered through the intravenous route, where it actually makes it to the intravenous circulation, and it ends to the right or the left side of the heart. Which side the intravenous ends up? Right side of the heart. So the intravenous goes to the right side, the arterial drug goes to the left side to leave the heart. So if you give a drug through the intravenous route, it makes it to the right side of the heart, then goes to the lungs, and this is where oxygenation happens and goes back to the left side, and from the left ventricle leaves to the rest of the body. And this is now it's into the main central compartment, which is the blood circulation. If you give drugs through the lungs, also they end up going to the left side and from there to the rest of the body through exchange between the bronchioles and capillary circulation. If you take drugs orally, they get absorbed, then they go to the liver, which is the first pass effect. And from the liver, go back to the venous circulation and so on. If you give the drugs intramuscularly, so it stays in the muscle most of the time as an oily depot, which delays the release or make it an extended release. Then from there, it goes back to the venous circulation and so on. Similarly, if you give the drug subcutaneous, the only difference, if you look at the diagram on the right side, what decides if this is a subcutaneous or intramuscular or intravenous, just the depth of the injection. If you just go to the superficial layer, you get the subcutaneous layer administration. If you go below the dermis layer, it's an intramuscular. If you give it directly into the muscles, obviously if you need the intravenous line, you have to go deeper than the muscles because the veins and arteries are structured or lying underneath the muscles. Okay, so this is on multiple drug delivery forms. Could be a tablet, or an injection, or even a cigarette. If you administer like marijuana, it's an administration route. It's through smoking. Suspension or patches for most of the transdermal drugs. Suppositories could be nowadays you find over-the-counter candy or gum. Most of the fibers are given as candy, or even the multivitamins are given as gum. Implants, and this is mostly like progesterone and estrogen, long-acting hormones. Gas or creams or others, such as Stams or bandana.
Can you explain what a suppository is? Can you explain a suppository?
It's a dosage form that's given through the rectum to bypass the first pass effect because it's actually avoid 50% of the drug loss. At the same time, it's simply you dissolve the drug in glycerine-based. Once it's inserted, then the glycerine-based starts dissolving and starts the absorption. So the formulation is different and has to be unique because of the limited volume of solution for the drug to dissolve. At the same time, it has to be easily disintegrating, and the micro size of the bundles have to be very small. So, if you're going to discuss the absorption, you have to know what's the difference between these different routes of administration and which route of administration works for what drug. The factors that affect the rate and the fraction of the drug absorption, if you take a gram of drug, how much of it will be absorbed and how fast of that drug will be absorbed. It depends on the route of administration. If you give it directly into the IV circulation, it actually makes it to the IV as soon as you finish the injection. So that injection may last a few seconds, then by the end of you pushing the last drop in the syringe, the whole dose is already in the circulation. So this is fast, and at the same time you can deliver as high dose as you want because there is no barriers. If you're gonna give the drug orally, you can decide, should I give the salt or should I give the actual base or the free acid? Should I have it enteric coated because this will protect the stomach or delay the absorption from the stomach to the intestine? Should I have it as liposomes? And liposomes are simply lipid-based capsules where the drug gets engulfed in it and then have higher access to the circulation. Long-acting dosage forms, it could be, there are multiple ways for making the drug long-acting. One of the easy routes is to make it microcapsules where every capsule will dissolve at a specific time. So they have tiny particles of the drug instead of one big bulk tablet. So you have tiny tablets within a capsule, and each group of tablets will dissolve after a few minutes, and after half an hour, and after 1 hour, and so on. So you have different layers of coating for these drugs, so they can cover different time frame of the solution. So some of the drug dissolves as soon as you get the capsules, then the remaining dose actually start dissolving later and gets to the circulation later. So you have a steady flow of drug to the circulation. Okay, so what are the factors that can affect drug absorption? First one of them is the drug pK, which is the negative log of the constant of the solution. The molecular weight of the drug, its lipid solubility, its chemical stability. So to discuss these drugs and these factors, just gonna have to keep up from to know what's slide we're on, just to keep track of time. So, for every drug, there is, based on the structure of the drug, there is a value which is called pK, which is the solution constant, or the pH at which half the drug will be ionized and half will be unionized. So there is an equilibrium between the ionized amount and the unionized. So if you have a gram, half of it will be ionized and the other half will be unionized. The lipid solubility is very crucial in the absorption of any drug. The drug has to be lipid soluble enough across membranes, but at the same time has to be also soluble in water enough to disintegrate in the volume of water that's existing as soon as you cross the membrane. So this balance between having good lipid solubility and enough liquid or water solubility or hydrophilicity and lipophilicity, so they have the balance between being a lipophilic and hydrophilic. You cannot have something that's 100% lipophilic because it's not going to cross through the water component as soon as you cross the membrane, because you know the cytosol is not purely lipid. Once you cross the plasma membrane, there's also a cytosol that have water contents and hydrophilic ingredients. Disintegration of a tablet or delivery formulation will affect how fast it dissolves and gets absorbed. Also, the properties of GI environment. If you start from the beginning of the mouth until the end of the GI, it's not one pH, and we have a slide for that. Every part of the GI has its own pH numbers that will affect which drug gets absorbed from which part of the GI. The transit time, how fast the stomach is emptying its content. If the stomach is taking forever to empty its content, that delays the reach of some drugs to the intestine to be absorbed. But at the same time, if the drug is intended to be absorbed from the stomach and you gave this drug in addition to another drug that increases the rate of emptying, which means the stomach is emptying its content fast and too fast for this drug to be absorbed, then you're actually reducing the absorption of this drug. Is this clear? The transit time. So for a drug to be absorbed, say if it's intended to be absorbed from the stomach, it has to stay there for enough time to cross the membranes from the stomach to the blood circulation. But if you have a drug that makes the stomach empty its content faster, you're not actually giving this drug a chance to cross this membrane. So the absorption or the amount absorbed will be reduced. On the other hand, if you have a drug that's intended to be absorbed from the intestine, and you're slowing everything by giving a drug that slows the movement of the GI, so the drug will be stuck for a longer time in the stomach before making it to the intestine to get absorbed, so actually delaying the absorption. Okay? Obviously, food and food interaction is very crucial. We used to spend 6 lectures in drug-drug interaction just between drug and food, because some of the food will affect the absorption, some of it will affect the action of the drug, or the function of specific bonds like glycoproteins. All of these will, you studied in details of actually going to go to the medicine or pharmacy route. So in general, what are the membranes? What are the barriers that the drug have to cross to reach the site of action? So you have cell membranes, which is permeable to many drugs, but not to others. So depending on their lipid solubility, this is number one, and the size. So the pore size between the membranes is 8 angstroms. Can anybody tell what's an angstrom, except those who have the notes in front of them? 10 to the negative 10. So it's 10 to the negative 10 of a meter. So the pore size has to be too small, which means the drug molecule or the unit of the drug have to be smaller than this size to cross the cell membrane through the pores. But it can cross through the membrane itself if it's lipid soluble enough. The walls of the capillaries, so you have drug crossing from the GI to the blood circulation. So it has to cross through the walls of the capillaries. And the pores between these cells are larger than most drug molecules, which allows them to cross freely back and forth to the blood, if they make it to the blood. But at the same time, if you go to a different compartment, which is the brain, you have the blood-brain barrier. It's made up of the same type of material or same type of cells, with the difference, it's now tied to the junctions, or the space between the cells is very small. This provides a barrier to protect the brain. Not every drug you take makes it to the brain on normal physiological conditions, because if you have inflammation, or if you have kind of diseases that makes the blood-brain barrier leaky, and this is the terminology that most people use, drugs will have access to the brain. So when you give a dose for a rat, you cannot really exclude that the action is given. It's mostly peripheral, because some of these drugs will have access to the central component and act on the brain. Especially if the animals have inflammation or after surgery directly, then the blood-brain barrier protection is embedded. Placental barrier, this barrier actually separates two distinct environments, which is the circulation between the mother and the baby. And we're going to cover later that the pH in the baby is different than the mom, which makes the drug can cross one way and trapped in the other direction. So this is a schematic representation of a cell membrane, where you can have the drug going through the paracellular walls or the pores between the membranes, or it can diffuse through the membrane itself if it's a lipid soluble, or it could be carried across the membrane by active transport, which is facilitated diffusion, or drug transport or drug-specific transport. The difference, one of them requires energy and the other doesn't require energy, but it depends on the transport. Okay? So these are the four ways that the drug can make it from outside to inside the cell membrane. Either between the cell membranes or across the cell membrane through diffusion, and this is governed by the diffusion law, which is concentration dependent. We're going to cover this in the next slide, which is known as fixed law of diffusion. And also the facilitated diffusion is based on this energy dependent carrier, and also the active transport through a specific transporter. So this is a depiction of plasma membrane. Probably you've seen this 100 times. What it means is the plasma membrane is not just one flat lipid layer. It has polar sides to the outside. This grayish material is polar component. The nonpolar is this long part. So the drug to cross this membrane have to have some polar solubility or hydrophilic solubility and some lipid solubility. It's not completely solid lipid. You have protein going across from one side to another, which can help transport some of the drugs from outside to inside. And also you have cholesterol components, you have phospholipid layer, and you have glycoproteins, which is a mixture of protein and carbohydrates. So this kind of variable structure will decide which drug cross the membrane and through which channel or through which route. This is a depiction of the blood-brain barrier. The only difference you can see between a regular capillary and the capillary in the brain that it has a second layer, which is what gives it its title junction. That second layer will help minimize, I'm not going to say completely eliminate, transportation of drug to the brain. It just limits drug access to the brain. So the first equations, and these equations are important to memorize, okay? Because on the exam you probably have to remember the equation and have to know how to use it. So diffusion across membrane, as we said, depends on the lipid solubility and at the same time the diffusion law, which is concentration across membranes. The first one is Henderson-Hasselbalch equation. This equation is actually decides how much of the drug will be in the ionized form and how much of it will be in the non-ionized form at any minute based on the pH of that solution. So the equation, and this is a simplified version of the equation, you can see it written by multiple routes. It's log protonated form divided by unprotonated form equal to the pKa of the drug minus the pH of that medium or that solution. Will it be the GI or the blood or even specific components or specific compartments of the body. This applies for basic drugs and acidic drugs. Notice protonated versus unprotonated, that will change which one is ionized, which one is not ionized. As a rule of thumb, those drugs to cross the membrane have to be, what do you think, ionized or non-ionized? Okay, who says ionized? Raise your hand. Who says non-ionized? Okay, non-ionized is correct. For any drug to cross the membrane, it has to be neutral, no charges. Ionized means charged, which means lipid soluble or water soluble. If it's charged, it's a water soluble. If not charged, it's a lipid soluble. So for a drug to cross the membrane, it has to be non-ionized, okay, no charges. For an acid, if it's protonated acid, will that be charged or not charged? Will it be ionized or not ionized? Okay. This is an acid here, protonated. So protonated means charged. For an acid, that means ionized, which means cannot cross the membranes. For a base, this has no charge on it. Because normally base is negative and the proton is positive. So that can cross the membrane. So the distinction between protonated versus ionized, you have to make the difference. If it's a protonated acid, it's ionized. If it's protonated base, it's not ionized. Okay? Then you know how much of the drug is in the protonated form, which can cross, or the non-protonated form, which cannot cross with base, and so on. Okay? You're gonna have at least one or two examples for you guys to understand that. Similarly, for fixed law of diffusion, the amount of drug that can diffuse through the membrane, regardless if it's soluble or not soluble, first it has to be lipid soluble. Second, how much of it diffuse is dependent on the concentration. How much of the drug is outside the membrane versus how much of the drug inside the membrane. So it diffuses by concentration gradient, which means the difference between the two concentrations, which is this one here. C1 minus C2, the concentration in the outside versus the concentration in the inside. When they are equal, diffusion stops, because that number, C1 minus C2, will be equal to 0. If I have 50 molecules outside and 50 molecules inside, the difference between them is 0. So regardless of what you are multiplying this with, the total outcome will be 0. So diffusion happens when you have high concentration outside to inside until they are equal, both sides, then stops. Then if you have a membrane this way, you have 5 molecules here and 5 here. It stops movement until you take one of these and move it somewhere else. Then another molecule will replace it, and so on. So diffusion is concentration gradient. It depends on how big is this surface area you're going through and how thick is this distance that you have to cross. So if you're crossing through a larger surface area, which is the top one here, the area, then that increases your chance of diffusion. If you're crossing, if you have higher permeability, that also increases your chance of diffusion. If you're crossing a thin layer, then your diffusion becomes easier, so it becomes more. If you have to cross a membrane that's this thick, that takes more time, more energy, then the thickness will actually negatively impact how much diffusion you have. So this diffusion, it's free, it's dependent on the concentration outside and inside, and at the same time, you have to be a lipid soluble to diffuse, so you have to be in the unionized form to be able to diffuse. At the same time, once you cross the membrane, it depends on how big this membrane surface area, which is the area of diffusion, and the thickness of the membrane that you have to cross. So let's start by Anderson has a Buck equation. So the acid plus its proton. In this case, it's not ionized. Once you split them, the protonated acid is charged. Okay, so once it's split, it becomes a base and an acid. This is charged. So this is a conjugated base. We call the A-negative is a conjugated base, and this is proton. And for the base, conjugated acid, once it's merges with the acid, becomes ionized. Okay. So what decides an acid or a base? Acid if the pKa less than 7, base if the pKa higher than 7. And you know the rule that pKa plus pKb equals 14. So that's why you split in half. If an acid has a pKa of 5, its pKb is 9 because they have to add up 14. Okay, but this may be not crucial for you guys. But with this format, we said if it's an acid, we said protonated divided by unprotonated equals pKa minus pH. So you have the pKa of the acid, you plug the numbers, and you have the pH of the medium. Then you can decide if the difference between these, for example, is 4. Yeah. This is negative, this is plus, and this is plus. Yeah, thanks. So the protonated acid is neutral, and the protonated base is charged with positive. Then you have a protonated acid, which the acid is combined with proton, and it's neutral and can cross the membranes. So I will ask you a question. In the stomach, would the acid cross or not? Because in the stomach, there's more proton, which pushes the equation to this route. So we have more of this undissociated form or protonated form, which is a neutral form. So if you take an aspirin, will it be absorbed more from the stomach or the intestine? Aspirin is a thiosalicylic acid, which is a weak acid. So it gets absorbed mostly from stomach because it's acidic. Okay? That's fine. I need them to say check from the background. So the base, on the other hand, in the stomach, you have more protein, which will push this format, which is ionized form. Then you cannot absorb the base from the stomach. Most of the bases are absorbed from the intestine when it starts to become more basic or more alkaline. Okay? So most of the alkaline drugs are absorbed from the intestine. Most of the acidic drugs are absorbed from the stomach. So this is like just an idea what's the strong acid, what's the strong base, based on the pKa. Strong acids have low pKa, and they will fall in this category here, the aspirin, and then the closer you get to the 7, becomes a weaker acid because now it's binding to a stronger base, and the other way around, strong bases that the closer to higher pKa, then the closer you get here, it becomes a weak base. Just look at the graph to get an idea what's the difference between them. You're not really going to be tested if this is a weaker acid or a stronger acid or stronger base. All you need to know how you plug in the numbers of the pKa and pH to get the equation of this protonated or unprotonated. Okay. So this is an example of absorption of a drug. So this is an acid, and the pH of the plasma is 7.4, and the pH of the gastric juice is 1.4, which is an acidic range. So when you have this kind of pH, and this is an acid, most of the drug will, this is like a heavier arrow, will go back to the HA, which is unprotonated, which cannot cross the membrane. Once it crosses to the plasma, this is like lipid membrane, okay? And the plasma is more basic or more alkaline. Then the drug will start shifting towards this protonated form or conjugated, like associated form, and then it traps in this format because this is the format and the pH. What's the pH of the blood supports having more of the associated form. Then it starts to be something called ion trapping, where the drug crosses the membrane, then becomes becomes dissociated and become ionized, cannot come back. So it's trapped on the other side of the membrane. And this is the way for the diffusion to keep going, that you send the drug from the stomach, crosses the membrane. This process is based on concentration barrier. But once it goes inside the plasma, it starts new transformation based on the pH and becomes a completely different molecule. Then the HA amount gets down. If you notice the numbers, if I have one molecule from here, another molecule from there. But because of the difference in the pH, it's a continuous flow of the drug from the stomach. Otherwise, if you depend only on the concentration and the gastric pH is similar to the blood pH, only half the drug gets absorbed and the other half will stay outside or stay in the stomach. It's only keep flowing inside because once it gets into the blood, it breaks down and becomes a completely different formulation, which is H and A separate instead of the unprotonated form. Okay? So you understand the idea of ion trapping and that the molecule of the same drug will change from unprotonated to protonated once it crosses the membrane based on the pH across the two membranes. Okay? The only difference is the gastric juice is an acidic. Once you go to the blood, it's more neutral, and if you go to a different part of the body, also could be more alkaline based on there's an infection or inflammation or so on. Okay? So, acidic drugs in acidic pH environment, ionized or unionized. This one. So, who says ionized? Who says non-ionized? Let's start by non-ionized. Okay, ionized. So, acidic drug in acidic media, non-ionized, which means it can cross membranes. Similarly, basic drug in basic media, non-ionized, can cross membranes. Acidic drug in basic media, like acetylsalicylate salicylate in the blood, is ionized, breaks, and becomes two charged components, so it cannot cross the membrane back to the GI. And similarly, basic drug in acidic pH, non-ionized, ionized, sorry. So the rule of thumb, acidic drugs become more non-ionized in acidic pH, so they can cross the membrane, and basic drug becomes more non-ionized in alkaline pH. So this is the idea of aspirin going from GI to the circulation of the plasma, then excreted in the urine, which is more alkaline. So the flow of the drug this way is because it's becoming more alkaline in this way. Where piperidine, which is one of the painkillers, actually is more concentrated in the GI than the urine. It takes longer time for absorption because of the pH flow. Okay. This is more explanation of the Fick's law, which we just covered a few minutes ago, is the law of diffusion. So the number of molecules per unit time, or how fast the drug crosses the membrane, is dependent on the concentration difference, C1 minus C2 across the membranes, the air multiplied by the area and the permeability coefficient, how big is this area and how fast this drug across the membranes, divided by the thickness of this membrane that the drug has to cross. Okay? The higher the difference in concentration, the faster the diffusion. And this is the area, this is just details about it. So this is another example, intestinal absorption. So this is how much of the drug is absorbed in 1 hour versus how much gets absorbed in 10 minutes in the intestine. So this is 1 hour from the stomach, you get 38% from ethanol, but if you go to the intestine, within 10 minutes, double this amount gets absorbed. Why? Can you guess why? It's mostly done by diffusion. So what's the difference between stomach and intestine? Surface area. It's a very large surface area. If you look at the intestine, it's very large, very irrigated, or microvilli and alveoli. It's very goes right and left, and it's probably 100 times the size of the stomach. So it's fast, even though the pH becomes more alkaline in this area. Because of diffusion, it was faster. Phenobarbital also gets absorbed more from the stomach, from the intestine than the stomach. So determined by great epithelial area provided by villi and microvilli, and remember Fick's law, diffusion, and the limit greatly for absorption of amine drugs, which is alkaline drugs. And tertiary amine is most commonly used or absorbed from the intestine. So this is the numbers for stomach and the small intestine and large intestine pH. And notice the difference between fasting and fed pH. Fasting is means there is no food. So the concentration of acid is very high because there is nothing to dilute the acid. And this is why you have a lower pH. So remember, what's the pH is negative log the concentration of acid. So if you have higher acid, you actually get lower pH. That's right, because negative log. And when you feed the animals or you feed a human being, you're actually diluting this with food and you're adding lowering the pH. Small intestine usually around 4 to 6, and different parts have different pH ranges. Then when you go to the large intestine, it's mostly also alkaline relative to the stomach. Carrier-mediated transport. Remember this slide? Instead, it is active transport, facilitated diffusion, and drug transport. Let's see what does that mean. So the drug can cross the membrane based on the just pure diffusion through the membrane or between the pores, but also can be carried across the membrane by active transport. Most of the peptides, amino acid, and glucose are examples of molecules that enter the cell through a special carrier mechanism. And that carrier mechanism, actually, if you can do research, becomes a target for drug intervention. Because if you interrupt this carrier process, you can prevent the movement of specific molecule across membranes. One of the easiest way of, for insulin or glucose to be transported across the membrane, it has to be carried with a carrier that's driven by insulin. If you target this process, you can prevent glucose from going inside the cell. If you have lower insulin or lower function of insulin, because insulin has to act on a receptor for that to be transported, then glucose will stay in circulation and you have a diabetic patient. So if you can increase the speed of transportation from the circulation to the rest of the body, you actually can treat diabetes. So this is how you think about drugs, how you develop a drug or how you develop a model of the disease so you can study action of other drugs. So active transport describes an energy requiring process. So it requires an energy. So this process is also saturable, which means it depends on the number of transporters you have, and it depends on the concentration gradient. One example of that is the sodium-potassium ATPase. Do you know any drug other than you that works on sodium-potassium ATPase? Very famous drug, very toxic drug. Okay, digoxin, sodium-potassium ATPase inhibitor. So simply it inhibits this bond, increasing the concentration of calcium inside the cells, and that increases the force of contractility. And this is drug used for congestive heart failure. So it's a drug, all its function is inhibiting the sodium-potassium ATPase bond. So it's inhibiting a carrier naturally functioning in the body. On the other hand, facilitated diffusion doesn't require energy, but also saturable mechanism. It depends how much carriers you have. So think about it as carrier like it's a train or train pathway, and you have cart boxes or different parts of a component of a train. You have a limited how many component or how many drugs you can carry on this train because it has a limited number of spots. So it's limited by the number of carriers you have. Example of that is glucose transferase or glucose transporter 4. So if you deplete the glucose transporter 4, you actually reduce the glucose transportation. Okay, so we're going to start introducing another concept, which is bioavailability. We know if you take a drug, it's affected by how long will it stay in the stomach, then after it gets absorbed, how much of it gets decomposed or broken down with the liver through the first pass mechanism, and how much of it goes back into the circulation or into GI through the enterohepatic cycle. The bioavailability is the way for us to put numbers. I took a gram of tablet, gram of one drug via an oral route. How much of it makes it to the circulation? Well, the whole gram gets in, and in this case means 100% of the dose is absorbed, or it's only like 60%, or only 50%. So that number, or that percentage, is the bioavailability. It simply compares how much of the dose that you take orally makes it to the circulation, or what's the concentration after taking two similar doses, one given IV and one given by oral route. Then you compare. When I took the same dose orally, I actually achieved less concentration, which means I'm not absorbing everything. Some drugs you can convert from oral route to IV route 1-to-1, which means the drug gets absorbed completely. So that depends on the drug, that depends on the pH, the particle size, and multiple factors. Okay, so this is a diagram of the concentration of the drug once you give the same dose. So if you give the same dose IV, you achieve high concentration and you start going down, because that's elimination phase. If you give it IV, it takes time until it reaches its maximum concentration, which is the time it makes it from the injection site to the circulation. Then once it reaches the site, it's obviously you did not achieve the same concentration, which means you lost some of the drug. Then you start breaking it down at the same rate, because that's an elimination process. It's not going to matter to the liver or the kidney how the drug made it to the circulation. Once it's in the circulation, it will deal with it the same way. The intramuscular, it takes a longer time to make the circulation, because obviously the absorption from the muscle, the lower blood flow compared to the IV, will take longer time. Then also starts eliminating. Here, you're giving the drug orally, so it takes longer time to mix it, and usually it doesn't make it to the same concentration. So if you have an estimation, how you can calculate the bioavailability of this drug? If you look at these two graphs, how you can calculate? Is it like 20%, 30%, 100%? Which numbers you take? You take this, the area under the curve giving orally, which is this area, versus the area under the curve giving IV, which is this area. And you calculate this concentration. Then you divide both. Divide the oral number versus the IV number. And just an estimate, this is probably absorbed 30%, because this area is probably 30% of this area. Okay? And that's why you never achieve similar concentration given the drug orally versus IV. And most of the drugs, although there are drugs that one-to-one conversion of 100% absorption. I'm not going to cover this, it's already in the book. That tells you what different routes of administration, what's good and what's bad for them. Controlled release substrate preparation. So the advantage of controlled release is simply you're delaying the absorption, which means you cover longer time of drug administration versus acting for short term. If you take a tablet, it will act immediately, you achieve a specific concentration and it starts going away. So you have this fluctuation in concentrations. Your level in the blood is not stable all the time. The advantage of controlled release, you're actually pushing the drug to the circulation gradually and continuously. So you're always giving enough blood to the circulation. So you maintain a stable level. We talked about sublingual administration. Simply, although it has small surface area, but it's bypassing the water circulation. It goes from the lungs to from the sublingual space to the venous circulation, bypassing the liver. So you're not actually losing anything in the hepatic circulation. And it's fast. It's usually within a minute or two. Transdermal, we talked about patches, nicotine and nitroglycerin, and now most of the drugs like hormonal drugs, testosterone, estrogen replacement therapy, is getting through patches that you put on the skin, and it goes through the skin layer and gets back to the circulation immediately because it's a living solid. Directed administration, 50% of this drug bypasses the liver, but that doesn't mean it's completely bypassing the liver. You have another 50 that goes through the first pass mechanism. Also, one advantage for giving suppositories sometimes is you bypass the cytochrome P450, CYP3A4. You're going to study, like probably in 2 lectures, the cytochrome P450s, different families and what they mean. It's a metabolizing enzyme that breaks drugs. There are multiple families, and this is where the name it's a category 4, and that's category 4 is one of the most common drug metabolizing enzymes. So it breaks most of the drugs, or it breaks a large number of drugs. It's highly concentrated into the upper part of the GI tract. So if you give the drug rectally, you're avoiding this high concentration of 7-AO4. If you remember from the last lecture, cyclopamine for 50 are focused or concentrated more in zone 1, 2, 3. Which one was it? That was only Friday. 7-cyclopamine for 50 are focused, concentrated more in zone 1, 2, 3 in the liver. Which one? 3. Zone 3, as you get closer to the central vein. Okay. So bioavailability, how much of the dose given orally makes it to the circulation compared to how much of it makes it to circulation if you give the same dose through IV. To calculate that, you simply say the amount of drug enters the systemic circulation divided by the dose administered. So that's the bioavailability. It's affected by multiple factors. First, now we're giving the drug orally, so it has to be absorbed from the GI. So the amount absorbed is one factor. Second factor is the first pass elimination, because when you give the drug IV, you don't see the liver. It goes directly to the circulation and you're done. But when you give it orally, you have to cross the first bypass, and you have to cross the portal circulation, and you lose amount of the drug. So if I give you a gram of drug orally, and I'm asking you what's the bioavailability of this drug, first you have to know how much of it was absorbed. When the whole gram gets absorbed, or maybe half of it. Then from the portion absorbed, how much of it was lost in the liver elimination, which is the elimination or extraction ratio. So we need to calculate multiple things. So for a drug, the drug is only absorbed, say, 70%. Other drugs may be absorbed higher, up to 100%. Then it's not enough. Once it's absorbed and crossed the membrane, then we have a mechanism to push it back. Our system is designed, this is a drug, this is a foreign body, I don't need it. And we have something called B-glycoproteins. Their function is to bump the drugs out. And actually they call it sometimes drug resistance bump, or drug resistance molecule. So this B-glycoproteins, if you inhibit this, you're actually concentrating the drug after the GI, or making the drug more absorbed, because you're preventing your own mechanism of kicking it back. And we have a lecture, I think we have a literature review this week, Friday, the issue group. One of them will discuss the B-glycoprotein inhibition and expression, and how does this affect drug concentration in the brain, because one of the most active sites for the B-glycoprotein is the brain, and it's actually one protective mechanism for you to kick stuff out of the blood-brain barrier. And if you have a drug that inhibits the B-glycoprotein, this means the drug will cross the brain and stays there, because you don't have the B-glycoprotein mechanism to take it out. One famous drug interaction is grapefruit juice. Grapefruit inhibits B-glycoprotein, which means if you take grapefruit before you take your medicine, then your chances of having higher dose is increased, and your chances of toxicity if the drug is very narrow therapeutic index, which means very safe and specific limit. Then if you cross that limit, you become toxic. Then it becomes a problem of having something that you never think about, which is a grapefruit. Okay, somebody taking a drug for losing weight and using grapefruit for a diet or something, then end up having amphetamine toxicity. Then you end up, because it will concentrate more in the brain, then you get side effects. So when you think about interaction, think about everything you take through the same route, even if it's just a diet or something like that. So the second part that impacts how much of the drug gets mixed into circulation is first pass elimination. I will cover this part and then stop. First pass elimination means I sent 100 molecules to the liver, how much of them made it out of the liver to the rest of the circulation, which is known as extraction ratio. So extraction ratio depends on how much of the drug gets cleared by the liver, which is the clearance or the liver clearance, divided by the blood flow to the liver. And these are fixed numbers for every drug. So every drug now is known how much of it gets released or broken down in the liver, and how much of blood we're getting through the liver. So when you calculate the extraction ratio for every drug, 1 minus extraction ratio. So for example, if I have 30% of the drug is lost or cleared by the liver, that means only 70% makes it out. But it's not 70% from the original dose, it's 70% from whatever was absorbed, which is this little f. So now we have to take two things. How much was absorbed, which is this ratio, and how much was remaining after we passed the elimination in the first pass effect. Okay? Let's take an example so we have numbers. Okay. We're not going to get to do the wallet distribution today. Okay. So for a drug like morphine, it's almost completely absorbed, which means the fraction absorbed is 1, because 100% of the drug is absorbed. So the loss in the gut is not really any, it's not mentionable. But the hepatic extraction ratio of morphine is around 60 liters per hour for a 70 kilogram substance. And also, the liver gets 90 liters per hour for that same substance. So if you divide the 60 by 90, that means for every 90 liters going to the liver is extracting 60 or clearing 60 liters completely from the drug. So 2/3 of the circulation going to the liver is being cleared completely from the drug. So 2/3 of your drug is being lost just by going through the liver. So if you divide 60 by 90, you get 67% or 0.67, 2/3. Subtract that from 1, that means what's left after going through the liver is almost 33%. Remember, in this case, there was no loss in the absorption. The drug was absorbed completely, but the loss was in the metabolism of the liver. Some other cases, you may have this number as 0.5 or 50%. So you lost 50% for absorption, then you end up losing another 30%. So you have to multiply these numbers. Then you end up, maybe what's left is very little, and so on. Okay? I'm going to go through this. Bioequivalency, and what does it mean to be pharmaceutically equivalent or bioequivalent? There's a distinction between two nomenclature, and this is the last slide. For two drugs to be pharmaceutically bioequivalent means they have to have the same ingredients. If this tablet from this company or the original company have a half a gram, their tablet, the other tablet have another half a gram, they're pharmaceutically equivalent. That doesn't mean when you take this tablet from company A, you get the same effect if you take it from company B, because the formulation of each company may be different. The absorption rate from these different tablets may be different because they're not bioequivalent. And now for any new company to come up with a generic and gets approved, they have actually to show that they are actually not only pharmaceutically equivalent. It's not that we have the same ingredient. No, we actually deliver the same amount of drug to the circulation, so are bioequivalent. So bioequivalent means that when you take the same drugs, you have the same extent of bioavailability of the active ingredients in these two products. And this could be affected by crystal form, particle size, or physical characteristics. One of the famous examples was the flagyl or metronidazole, which is anti-parasitic drug. When it was introduced as a generic, the new generic drug never delivered the same promise of treatment because they did not know how to microcrystallize their tablets or their powder. So the drug never actually made it to the circulation at the same level was the brand name drug, and it was the problem at the beginning until they realized, oh, we have to microsize the drug. We have to make it, the particles of the powders very small for them to cross all these barriers and make it to the circulation at the same concentration. We'll stop here, and then we'll discuss this next time. Okay?